Welcome to the 5th webinar in the MGHS Institute Interprofessional Webinar Series. My name is Pauline Lesage. I am a physician educator at the MGHS Institute for Innovation in Palliative Care. Today we are going to address the question of prognostication. This session is divided into two. The first part, which is today, we'll talk about prognostication in cancer patients, and the second part, in 2 weeks, will address prognostication in chronic illnesses. I have no financial arrangements to declare. Before we continue and before we go forward into this discussion today or into this talk, I'd like to mention and make a few points. The first one is that prognostication is not an exact science. It's not a certainty. And I want to make sure that whatever I'm going to say during those two seminars, that they are not really something that we can count on the days. Even though we say we have 12 days to live or things like that, it will never be a precise number. It will always be a range. So just for you to know, just because we all know that prognostication is not something that it is really exact. So therefore we have to take that within a range. The second point I'd like to make is that even though we are oftentimes reluctant to talk about prognostication, thinking that we don't want to play God, we don't know, and we often answer no, we don't know, I think it's a must. It is something that we need to do. And I'll demonstrate today by answering one of the questions, the importance of prognostication, why it is something that's so important and that needs to be addressed. The third question or the third point I'd like to make here is just to put yourself into the shoes of a patient who has advanced cancer or advanced chronic illness, and you are going at your physician or your healthcare professional. And what would you like to know? Do you think that you will also be open to have, wouldn't you like to know the prognostication, to know where you are going on the road of this illness? So I leave the question open there. We'll see after the presentation, see where you stand at, and maybe we can have some discussion further on that point of view. The fourth point is that maybe prognostication is not for everyone, and I know that some of you will say, well, what's about if the patient doesn't want to know? That is correct, and that I agree with you that prognostication is not for everyone, but that is the exception. So let's go ahead and try to go with what usually should be the norm. Today we are going to see and talk about the illness trajectories. Then we are going to the main part of the topic. Discussion will be the formulation of a prognosis, and in that we will address different elements that we consider into the prognostication in order to get to a prognostication score. And finally, we'll address the hospice determination of terminal diagnosis, especially in cancer population. Again, a reminder that prognostication is not a certainty, but a way to respond to our quest of knowing what is ahead and planning for it. Why shall we prognosticate? Why is that so important? And I think that the first of this answer can be answering the question of the patient with reasonable certainty. Patient is there coming to you, wants some answer. Some will ask questions more than others. Some won't add that terrible question, how long, doctor? But most of the time, they will ask some questions. And then we have to be able to say something and not just say, well, you know, I don't know, it's hard to tell. It's not reassuring by having such a thing. When, of course, the answer is, I don't know, we say that, and it's welcome to say such a thing. But perhaps point to them what are the elements that we should consider in order to know where we are on this curve of the illness. The second question is that for the patients to develop insight in their illness. I don't know if you've ever been at the bedside of some patients who are literally dying, and it's almost obvious. And we see family or visitors coming, bringing balloons, get well, or simply saying, well, everything will be fine. Well, it's not fine. It is sometimes we are just playing a role that's not really what it should be said. And even though we don't want to discourage the patient, we want to maintain home at any time, but sometimes, hiding behind some not truth may do more damage than it can be good. What's about this patient who wants to prepare for something? How oftentimes we've seen patients who would have liked to do a last trip or do something, or travel, or get married even at times, and they won't have time to do that because they were not told that time is running, and eventually it will be too late to do such a thing. So again, this is some insight that the patient needs to get into their illness, and I don't think that we can deprive them from this knowledge. The other reason can be to give the appropriate setting of care for the patient. I don't know if you notice, some of us who are practicing in a hospital oftentimes do consultation in the emergency room, and it's not unusual that we will come at the same time as the medical ICU people will come, and then there will be a discussion over where to go, where the patient will be best suited, medical ICU versus palliative care versus hospice. And as you can see, all of that will play on the goals of care and how much time and how much benefit the patient will get out of going to one place or the other place. Giving proportionate care, chemotherapy or any other treatment, it's great when patients receive chemotherapy and they can benefit from that, or radiation therapy, or a transfusion, or any of those advanced treatment. But if it's not benefiting the patient, if the time frame is not really the right one, transfusing a patient who is, walking and having some symptoms is great. Transfusing a patient who is bedbound, has a low Karnofsky, as we will see later, maybe not the best idea. So again, time is really behind everything we do in palliative care and hospice. Communicate between the different team also. It's surprising that we see the team not always on the same level as we can be in hospice or palliative care, because their thinking may be different, their goals can be different. They need sometimes to be reminding that time is of essence, and then eventually if we look at the certain elements, we are not going to go forward. And of course, offer timely palliative care or hospice enrollment, as we can see today later on. Do patients want to know? Most of them want to know. The literature is really striking about that. There's of course a few exceptions, and we need to deal with those exceptions, but usually patients want to know. This is just a slide that has been around for a long period of time, and just show or illustrate to you that there's two type of services that we can receive in the healthcare system. And one is represented by the red triangle, which is disease-specific treatment. When the goal is expecting to help the patient to recover from the disease. This is usually represented by the acute care. You have the palliative care triangle, the green one, who is a triangle, which is a triangle that the more you'll be advancing the disease, the more probably will be the right place to be. The problem with those triangles is that they are not totally away one from the other. They can be complementary at times. You have patients on palliative care who need sometimes disease-modifying therapy. They will receive a treatment, an acute care treatment for pneumonia, for whatever it is, and so therefore that is feasible. But of course, the more the patients will progress along an illness trajectory, the more it will become more suitable for palliative care. The worst that can happen is that the patient is in the wrong system and receive too much care when he should receive less, or vice versa. Just a reminder here that patients with cancer who decided not to receive any treatment, no chemo, no RT, no surgery, still have a survival curve. And this is sometimes something that we tend to forget, and we should have that in the back of our mind. Example, a patient with stage 4 breast cancer can still have a year and a half to go, depending on which organs are diseased. So therefore, just have that in mind, that there's also a curve or a line for survival in patients without any treatment. Illness trajectories. Just by looking at this picture, you can understand very well what prognostication is all about. If you look at the first black curve, which is more of a 90-degree curve, it's a sudden death curve, and in this curve you cannot predict anything. A patient walk out of the office of physician, had a massive MI, and that's it. It was not preventable. It was not by definition sudden is sudden. Cancer death is, as you can see, a very smooth curve. This is a curve that's going down, but without bumps, so you can foresee things. Although you still can have patients who will die abruptly or suddenly in about 5% of the case with cancer, but usually you can foresee that the last few months. The curve of end organ failure as well as dementia is, as you can see, very downward, like all the others, but very bumpy, meaning that all those diseases like CHF, COPD, if you have an acute exacerbation of the disease, which will be a downward curve, you can fix sometimes some of those by changing the medication, by admitting the patient to the MICU, or doing a few changes. And the patient may recuperate somewhat and even get a little bit higher than when he presented to the hospital. But as you can see, in both cases, the curve is usually going down. And this is something that we are going to address fully in the next presentation when we are going to talk about the chronic illnesses. So again, keep that in mind. It's a bumpy curve, but it's still a curve that is going downwards. So every time that this patient is hospitalized or is sick, he is getting closer to a end-stage disease. What can we look into to make a good prognostic? And these are some of the elements that has been considered, and we are going to discuss one after each other. So the first one will be the clinician estimate of survival. So what is this? This is something that any good professional will look at a patient and will just estimate that his survival is, by the way he looked, the way he behaved, and so on, is such and such. So it is just a subjective evaluation of prognostication. There has been multiple studies on that. Christakis is one of the authors who wrote many articles on this. Lehman is on one of those as well. And it seems that the conclusion is that we are good, but not so good. It seems that it's inaccurate in about 30% of the cases, which leave 70% we are not so bad. And most of the time it is for being too much optimist. It's part of what we do. We try to encourage people. We try to make sure that hope is high. And of course, we tend to be giving it a bit more time than we probably know that it does exist. And we are usually incorrect by a factor of 3 to 5. And multiple studies show that. There's also variables depending who you are. A physician, the closer you are to a patient, the longer you follow a patient, the not so good you will be, because you tend to see more so objectively, but you tend to see with your emotions or your attachment. And it's hard to put that aside and have just the facts and be so objective. So this is why some will say, and I'll go back to that slide, some will say that a disinterested physician, like a physician in palliative care or in hospice, who will come de novo and just see the facts in front of him, may be able to have a better prognostic skill than maybe some physicians who are with long-term relationship with their patient. Now we do see that a lot of physicians are reluctant, I should say physician, I can say nurse practitioner as well, or anyone who has to do a prognostic, that we are reluctant to do so. And it has been shown, Dr. Zanartu did a very good study 2 years ago demonstrating the reasons why we are so not wanted to use prognostic tools. And one of those is that we have not been exposed to them with medical school. We were not taught that. There was not, certainly not something in priority, obviously. And so about in 50% of the case, that was the reason that's invoked. Well, fine. From now on, from today, we cannot invoke that because you will be informed. And so therefore, this reasoning is out for us. The second is that it's time consuming. And I hope that I will be able to show you today and also in the next talk that it doesn't take long. It is just, it's done at the bedside. If you know your tool, your instrument, it's just 1, 2, 3, and that's it. So time consuming is not really a good reason. Difficult to remember. Well, with all the instruments we do have now, with the iPhone and with all those gadgets that we do, we just have to press a button and the instrument or the tool will come in front of you and then you just add on. So I don't think that this is a real reason either. So the 3 first reasons, which is account for more than about 75% of the reasoning why we should not use that, are really not that valid. The role of the disinterested physician, we said something about that. Now let's talk about the performance status. Performance status is one of the old friends that we do have. For a long, long time we are using performance status to help us to see where the patient can be in the course of his illness. And it has been studied extensively. The Karnofsky example is on board since 1948. PPS is a little bit younger, and the ACOG, but still those are very all around. The thing to know here is that all of them, whatever you use, Karnofsky, PPS, or ACOG, are more or less similar. They measure the same thing, which is the functional status of the patient, and they are more or less equivalent. A Karnofsky, a high Karnofsky will equal the same with a poor ACOG and so on and so forth. I'll show you in the next few slides. This is just a quick look at the Karnofsky that shows 100. It's a scale from the 100 to 0, 100 being that you have no evidence of disease and 0 you are dead. And in between there's a scoring showing how deteriorating patients can be, starting with at 60% when a patient starts to need assistance and require more and more, which is going down in the scale. This is the full scale, as you will find it, that shows you at every 10% how you are, what you are at. Just to show you a relationship between the KPS and the life expectancy, and you can see that either for hospice patient, for advanced cancer patient, or for palliative care patients, you know, if you have a Karnofsky of 10 or 20%, the median survival will be 2 weeks. Again, 2 weeks, more or less, few days here and there, before and after, but that will be grossly. We are not talking about months. So below 50%, this Karnofsky scale is becoming very, very significant. So again, it's good to keep that in mind. The ECOG is a performance status also that is mainly used by oncology group. It's a reverse a little bit of the Karnofsky in the sense that 0 is fully active and 5 is dead. It started to be extremely significant when the patient gets to 3 and 4, meaning at that point the patient needs to a lot of assistance. He is halfway in bed, and you will often hear oncologists saying, well, if the patient has an ECOG of 3 or 4, we'll be probably reluctant, start thinking if really we should continue the chemotherapy. So again, this is a scale that is, and we can see a comparative equivalency here, that the ECOG and the Karnofsky can be used indiscriminately. I suggest strongly that you use one, you know one, and then therefore you become so familiar with it that you do not have to struggle each time. The palliative performance scale is an add-on developed mainly by the palliative care people, and it's more or less, it's a modification of the KPS. As you can see, the full two elements are the same, the ambulation and the activity level, and it adds on the self-care, the intake level, and the level of consciousness. It's a little bit more complete, a little bit more time-consuming, although not so much. As you can see, it's easy to fill up. But then again, it's equivalent to the Karnofsky. You cannot have, example, a PPS score of 50% and a Karnofsky of 10%. This is probably not. You may differ by a 10% or 5% of something on the scale, but probably not. So both of them are really a good way to give us the level of activity of a patient. Symptoms. Are there some symptoms that are significant if we see them that we should think that it does not look so good? And yes, they are, and then again, there's extensive literature on that. I'm just showing you a few results of that. And we know very well that some symptoms like anorexia, confusion, which used to be called terminal confusion. We are talking about here, of course, of symptoms that, the same for dyspnea, symptoms that are not easily reversible and just go on, and so therefore we're talking about those symptoms. And when we see them, I think we should be very careful, because eventually time is limited to a month or two, and that is something that we take into consideration. Quality of life, interesting. There has been also studies showing that just the distress associated with the symptom is an independent marker of survival. So again, the more distressed a patient will be, the least likely the survival will be long. Biologic parameters, again, multiple studies you can see here, and there's even some others that are not included in that list, that consider, is there a measurement of something we're just looking at and we'll be happy and say, well, you know, it's in the blood and this is it. And no, unfortunately, it's not like a thermometer, and we don't have such parameters, but we do have some biological parameters who help us to, by looking at them, saying that again, time is maybe off limit. So the most studied, I think, and the most commonly that we do see is the serum albumin. And you will see that this is the one that Hospice has retained as one of its criteria. Now, none of them in single can maybe be helping us too much for prognostication. They are indicators, red flags along the road, but maybe not enough. What's about, though, the idea came to some researchers to say, what's about if we were using prognostic scores in models? Let me talk to you about, in the last 10 minutes, that's our left here, about the scoring models that we are, that they are there, that we can use in cancer population. There are multiple here, this is just an example, and we are going to just talk about the PAP score and the PPI score. The PAP score is an exponential multiple regression model. What the authors did is that they studied about 500 patients with cancer, and they were looking at the variables that are the most significant of poor prognosis. Then, according to a regression model, they retain the clinical biologic variables that were the most significant. Then they give a numeral score to each of the variable, and the score was according to their how they were predictable for poor prognostic. They add this on, and then they ended up with a highly predictive scoring system for terminally ill patients, a score that is good for 30 days. So you can see here, example, on the left-hand side, you have the variables that they consider being the most significant. In this case, dyspnea, anorexia, the Karnofsky, the clinical prediction, as we mentioned before, the total WBC, and the low lymphocyte count. And you can see for each variable, they give a score, and then they added the score. They ended up with 3 categories, A, B, and C. And you can see that in the category A, it's difficult to prognostic anything because the 30-day survival will be more than 70%, therefore it's more or less useful. But the category C, who had a high score, it is showing that less than 30% will survive 30 days. Therefore, it's becoming more significant. And not only that, and you can see a schematic representation of that, they did also a validation of their score, and they ended up having, again, 3 groups, more or less like they were having in the initial tests that were done. The PPI is an interesting also scoring system, and which is interesting is that it considers different variables. Like example, on the left-hand side, you will see that they consider the palliative performance scale, which is more or less equivalent to the Karnoff scale as we mentioned before. But they consider the oral intake, the edema, dyspnea, and the delirium. For them, delirium is really significant. If you have a severe delirium that's not reversible, give you already 4 points, and 4 points is really a bad prognostic. The reading of the PPI is the following. If you have, example, a score more than 4, your median survival days will be something like 12, so more or less than 2 weeks. So again, what is interesting is that if you do a PAP score and a PPI, they are more or less equivalent. You cannot have a high score on a PPI example and a low score on the PAP score. So that's interesting because you can do either or both and see really the end results. So 83% sensitivity, which is quite good. So now let me just talk briefly about hospice. And as you know, the whole hospice admission criteria are based on a prognostic tool, which is a 6-month survival. And so that we like it or not, we have to be into grip with this prognostication because we will have to use that in order to refer our patients to hospice. So how do we know that patient has really a terminal illness? And now I'm going to talk about only on cancer, which is the topic of today. So there's about 3 different things that we can look at to see that patient is really in a decline and probably a good candidate for hospice. First, there's the decline in the clinical status of the patient. Second, there will be the non-disease specific baseline guideline, and the third will be the disease specific guidelines. So what do we include in the decline in clinical status? So that is to say that for any disease that you do have, cancer being one of those, you have a worsening in your clinical status, in the symptoms, in the sign, in the laboratory, or in the test that you do, CT scan and so on and so forth. So you can see that the disease is progressing. You can see that also in the Karnofsky performance scale, as we mentioned before. And also, which is very, very telling, and then we are using that oftentimes to refer patient to hospice, is really the history of increasing ER visit, hospitalization, and day visits that's related to a diagnosis. So much so that it's almost now an indicator when we do see that patient is referred many times, it is a criteria to be referred to our palliative care team because we know that eventually the patient is on his downward curve and we would like to refer him sooner than and later. Non-disease specific guidelines will be the Karnofsky or the PPS score, the fact that the patient needs assistance. If you don't want to use a Karnofsky, that he needs assistance for many things. The more assistance he needs, the worse things are. And also the comorbidities. It's important to know that every comorbidities that is adding on to a disease that the patient already has will decrease your survival. If you have example, and we'll see that when we have chronic illness, if you have only disease, chronic renal disease, and you are in hemodialysis, your survival will be X. But if you add to that a cancer or something else, you will see that your scoring will increase significantly and your lifespan or your survival will decrease. Patients, the specific the guidelines for patients with cancer are twofold. One is really a patient who has a metastatic cancer, so a stage 4 cancer, or a patient who has an earlier stage but the disease is progressing rapidly in spite of therapy, or the patient declines further disease-directed therapy. So these are the specific criteria for hospice. In conclusion, let me tell you that I think that prognostic estimate, even though it's inaccurate, even though it's not exact, it's a central element of both patient and physician decision-making. If we come to a patient and if you always can say, I'm not sure exactly, these are statistics, these are not really exact measurements, but I can tell you, if I look at the Karnofsky, if I look at the fact that you have terrible symptoms, the fact that you are, your labs are not all that great, and so on and so forth, if I add all that together, it does not look too good. So we are optimists, which is good to be optimists in life, but maybe not in this case, in the sense that if we are too optimistic, give too much time, we may cut, or we may not give enough time to the patient to prepare for what he would like to do. A last trip, a will, a living will, or a will, or get married, or whatever their wishes are. Patients with advanced cancer who are frail, who have a Karnofsky in the 20s, who are losing weight, who are bedbound, this is really, time is really running backwards, and there's limited time to go, 1 to 2 months or 4 to 8 weeks. So again, knowing the prediction tools will help us to make maybe better prognostication and help our patient to cope also with their diseases. So now we are time for question and answer. I hope there are many, and we'll be more than happy to answer them. Let me though ask you and add, one of the questions here is about the how do we deal, is the social worker staff or the chaplain or any other member of the team can help in the prognostication. And I think that it is a team effort, even though I may not have mentioned that into this presentation. But it is, of course, the physician, nurse practitioner, or the healthcare professional who know a little bit more about what to look at. But once the diagnosis is made and once the prognosis told to the patient, it is really it is great to have the whole thing to help us to support the patients and family to deal with the consequences of this prognostication. And I still remember when I was in a clinic, our social worker sometimes was the best one to repeat in her own words what was said and put that in terms that was making sense for the patient and was certainly supportive. We may not be the best one to, as physicians sometimes, to say things either with the language or and we are not always there neither to be at the bedside of the patient. Sometimes I would notice that the nurse, social worker, or chaplain will present facts differently, give them another dimension that will help the patients to go through that. Are there tools specifically for children? They are. Unfortunately, I'm less versed, or not versed, I would say, in pediatrics, but they are, I'm sure there is something. And it's, as you know, palliative care and hospice in pediatrics is in developing much and much recently, and then eventually there will be many tools. Which I did not say about the tools is that those tools are constantly reviewed, and you will see, especially in the second part of this, that there are many, and some are better than others. They are revised also, and with our knowledge, because we see more and more patients with advanced chronic illnesses and cancer, that we improve them significantly with time. How do we engage specialists better in talking openly about prognostic? They usually give a vague. I think so. I think that most of us, we tend to be vague. And this is why I'm doing those two lectures on prognostication, because even though we are not exact, we cannot 100% be sure, we can at least be a little bit more approximative. And answering that and being vague does not help anyone. And I think that this is why I think we all have, as healthcare professionals, learn about those tools. And those reasoning that we were saying before, that it takes too much time, that they are not enough accurate, I think that they are really false reasoning that we are giving ourselves to just to say, well, we should go this way or that way. I'm telling you frankly, in all the family meeting we had with family and patients in the past, when we were coming to them and saying, well, you know, I did look at this and that and all the elements that we discussed today, and we say, well, this is not looking so great. We may be wrong, but, you know, and they were welcoming that. They were thankful to us. They were having a sense that it was not like that we were paying attention to their questions, and eventually we can be wrong, but they were at least were having something to hang on. Other questions, there's multiple questions here. Is there an urgency as a field to update prognostic guidelines? Yes, they are, and they are, as you know, and we will see that probably with the AHPCO guideline also in hospice, that those guidelines are revised because they keep changing. A good example will be HIV/AIDS. We know that the prognostic was so poor, so bad. Now it's a chronic illness, and prognostic, we are looking at different elements that was there before. Can we prognosticate about all major diseases? Almost all the diseases now have some tool to prognosticate, including in the MICU, including for acute episode, for chronic episode. It's becoming, you can spend a lot of time just reading about prognostic. There are entire books who talk about that, and you can become almost a subspecialty because there's so much that we need to know. Of course, for the daily living, we should know just the basic one, and unless we are in a hospice and palliative care or need to discuss that abundantly, I think we should really go with the major or the most accurate, or the one that has proven to be the most specific to deal with. Perhaps another question here, the notion of hope. If patients are still hopeful, how can we? And then again, I will conclude on this question that, and all my life I've been in palliative care for about 30 years now, and that has been a question that from day one it has been always a question that how to maintain hope by telling the truth, by telling the patient where we are at. And after all those many years and after trying all kind of ways, I still believe that hope is not related to time. There's no equivalent between hope and time. It is the intensity, it is in the way that we are going to tell patients what we know, where we are looking at, that we will preserve in a way their hope. Some people will never have hope in their life, and of course the minute that they will have a negative story or a negative value or negative things in their life, they will just simply collapse and they will lose all hope. They are not optimists by nature. And of course those patients will need probably to be given news differently. It's in the way we say things and maybe not what we do say things. Hope is one thing, time is another thing. And also you have to see the reverse of not saying things or saying too much time or giving too much time than it is really. In fact, is that you may not give the person or you will deprive the person of the reaction that will be the real reaction. This conspiracy of silence, which has been a lot of literature written on that too, has not been proven to be all that great. I estimate that all of the patients, that most of the patients, as I said, there's a few exceptions, that we do see are adult enough, strong enough to be able to cope if we help them with help. And this is where the whole thing comes around, to cope and transform their life, transform the bad news in something that will help them to go forward. How many, when receiving prognostic as part of cause, became different or make a better living because they simply knew that time was of essence? So I will stop here for the questions. Thank you so much to attend this. And just a reminder that the next webinar will be in 2 weeks, December the 11th. And please make sure that you complete the webinar evaluation. As you know, this is helping us to plan ahead and to find topics for our future sessions. Again, thank you.